Every time a human foot impacts the ground, it absorbs mechanical forces far exceeding the body's total weight. For a healthy patient, the nervous and structural systems manage this pressure effortlessly. For a patient with diabetes, that same mechanical motion carries severe risks. The clinical data reveals a lifetime foot ulceration risk of 25%, with a 2% annual incidence rate. These ulcers do not occur as random complications of hyperglycemia. They emerge at the end of a highly predictable, step-by-step biomechanical failure. That failure requires 3 distinct component causes to interact. First, the nerves degrade, stripping away the patient's ability to feel pain or pressure. Second, without proper motor nerve function, the musculature imbalances, pulling the bones into rigid structural deformities. Finally, those deformed bones press outward against the skin during normal walking, creating repetitive, localized trauma. Once these 3 factors overlap, skin breakdown begins. Preventing this outcome requires clinicians to move beyond passive observation. Instead, the diabetic foot exam must be executed as a strict, active data processing algorithm. The examiner tests for neuropathy, looks for deformity, and checks vascular flow. The inputs from these 3 tests compute a precise risk classification, providing the specific timeline needed to intercept an amputation before tissue necrosis begins. The first input in the algorithm evaluates the neurological threshold. The goal is to identify the exact point where a patient can sustain physical tissue damage without feeling it. In clinical terms, this specific sensory deficit is defined as loss of protective sensation, or LOPS. This diagram illustrates the primary diagnostic tool, the 10-gram Semmes-Weinstein monofilament. The examiner applies the nylon tip perpendicular to the skin, pressing until the filament buckles, guaranteeing 10 grams of force. It is held in this position for 1 second before releasing. During this test, examiners must navigate away from any areas of callus. Hardened skin masks pressure perception and immediately yields a false negative result. The protocol maps out 4 mandatory testing sites on the plantar surface of each foot, the 1st, 3rd, and 5th metatarsal heads, along with the plantar surface of the distal hallux. To maximize diagnostic accuracy, the monofilament should be paired with 1 additional neurological assessment, typically a 128 Hz tuning fork for vibration testing, or a disposable pin for pinprick sensation. The criteria are absolute. If a patient registers 1 or more abnormal responses across these tools, LOPS is confirmed. The examiner requires at least 2 normal tests and 0 abnormal tests to rule it out. Confirming loss of protective sensation immediately flips the patient's risk profile from standard monitoring to high alert. With the sensory warning system offline, the algorithm directs the clinician to locate the mechanical hazards that will cause the physical damage. We now move to the musculoskeletal assessment, where we observe how nerve damage actively alters the physical mechanics of the foot. As motor neuropathy advances, it causes muscle imbalances. These imbalances create rigid structural contractures in the digits that the clinician cannot manually manipulate. This medical illustration demonstrates common forefoot anomalies, the claw toe shown here and hammer toe. Notice the mechanical shift. These contractures redirect normal walking pressures, forcing increased weight onto the dorsal surface of the buccal digit and driving the plantar metatarsal head into the floor. Those newly formed, highly focused points of pressure act as the localized trauma. It is the final physical catalyst required to tear through the tissue of a neuropathic foot. Moving backward from the toes, examiners must inspect the midfoot for Charcot-arthropathy. It is a highly destructive neuropathic condition, frequently misdiagnosed in primary care. In its acute phase, Charcot presents unilaterally. The patient will display a single red, hot, swollen, and flat foot. Because there is no open wound, clinicians often mistake this presentation for standard edema or an infection. If that acute phase goes unmanaged, the skeletal structure of the midfoot completely collapses, resulting in the rocker bottom deformity shown here. This collapse reverses the natural weight-bearing arch. The bones push downward toward the floor, generating massive pressure directly at the plantar midfoot. Because of the rapid structural devastation it causes, any suspicion of Charcot-arthropathy demands immediate, mandatory referral to a specialist. By identifying these skeletal anomalies early, clinicians can predict the exact geographical location on the foot where future skin breakdown will occur. The third and final data input evaluates the blood supply. Peripheral arterial disease, or PAD, is a compounding cause in 1/3 of all foot ulcers. Every patient requires baseline vascular screening. The examiner physically palpates the posterior tibial and dorsalis pedis arteries, characterizing the pulses simply as present or absent. If pulses are absent or the patient reports vascular symptoms like claudication or rest pain, the algorithm triggers an immediate requirement for ankle brachial index, or ABI, testing. This schematic details the ABI setup. The clinician uses a Doppler probe and blood pressure cuff to measure systolic pressure at the arm and ankle. The examiner divides the ankle systolic pressure from the posterior tibial or dorsalis pedis arteries by the higher brachial pressure. An ABI below 0.9 is abnormal, indicating restricted flow. An index dropping to 0.4 or lower indicates a severe lack of perfusion, resulting in ischemic rest pain and rapidly advancing tissue necrosis. However, diabetic patients present a specific diagnostic trap during ABI testing, known as medial calcinosis. Medial calcinosis physically hardens the arterial walls with calcium deposits. The arteries become so rigid that the blood pressure cuff cannot compress them. If the resulting ABI calculation comes back greater than 1.3, it does not indicate excellent blood flow. Instead, it signals that the reading is falsely elevated and inaccurate due to arterial calcification. When an examiner hits this false threshold, they must bypass the calf and ankle entirely, utilizing toe pressure measurements or transcutaneous oxygen tension testing instead. Verifying vascular supply is the final variable. It reveals if the foot has the biological capacity to heal a wound when the skin tears. Raw clinical data concerning sensation loss, deformity, and vascular pressure is useless in isolation. It gains utility when synthesized into a predictive, standardized action plan. The data is structured into a 4-tier risk classification grid. Category 0 means normal sensation and no arterial disease, requiring annual exams. Category 1 is triggered by loss of protective sensation, increasing follow-ups to every 3 to 6 months. Category 1 shifts the clinical plan to consider accommodative footwear or prophylactic surgery to manage contractures. Risk Category 2 involves compounding dangers, both loss of protective sensation and peripheral arterial disease, requiring follow-ups every 2 to 3 months. Category 2 automatically mandates a referral to a vascular specialist. Risk Category 3 is the highest alert level. Any history of foot ulceration or amputation. They must be seen in a specialty clinic every 1 to 2 months. A Category 3 patient requires maximum intervention because their clinical history proves that their physiological pathway to tissue necrosis is already active. The comprehensive foot examination converts silent pathological variables into a rigid, non-negotiable protocol. By isolating the exact factors that drive skin breakdown, this assessment provides the data required to stop the progression toward amputation.